Hello, my name is María Ballesteros-Pomar, and I am the head of the Clinical Nutrition and Dietetics Unit in the Complejo Asistencial Universitario de León. And also I am the coordinator of the area of nutrition of the Spanish Society of Endocrinology and Nutrition. Here are my disclosures, being the most relevant one that Nestlé Health Science funded an initial virtual meeting attended by all authors in the present work, where the unmet needs and subsequent recommendations for the topic were discussed. After the meeting, we worked in this paper, which has been recently published. The aim of the paper is to present an expert-reviewed report on evidence-based optimal practice and positions on the nutritional management of dysphagia, where this evidence is available, and a collective opinion on better practices to manage dysphagia in nursing home residents, where empirical evidence is absent. Before explaining our paper, I would like to thank my colleagues for their excellent contributions for the work, as this opportunity to research and share reflections with them has been a very stimulating and learning experience. And of course, a special thanks to Nestlé, and especially to Nuria Barcons for her support and enthusiasm for the project. This paper has a specific focus on the role of texture-modified diets and on unmet needs that should be addressed in several areas of care and research concerning oropharyngeal dysphagia, as you can see here in the slide. The long-stay nursing home resident population has specific characteristics marked by a shorter life expectancy relative to community-dwelling older adults, high prevalence of multimorbidity with a high rate of complications, dementia, frailty, disability, and often polypharmacy. Oropharyngeal dysphagia is believed to be common among this population, but this population also has a significantly greater risk of malnutrition, with levels ranging from 1.5 to 66.5%, depending on how malnutrition has been diagnosed. Oropharyngeal dysphagia is then associated with a higher risk of malnutrition, which further exacerbates oropharyngeal dysphagia. The prevalence of mealtime difficulties, including but not limited to dysphagia, is very high among nursing home residents. A cross-sectional study assessed the prevalence of these mealtime difficulties, and they found 54% of the mealtime difficulties when residents were on a regular diet and 46% on a texture-modified diet. Due to the large heterogeneity within the nursing home resident population, defined resident-specific care needs, including nutritional goals, are urgently required. Personalized resident-centered care planning needs to focus in the management of care of oropharyngeal dysphagia. Based on the author's personal opinion, optimal nutritional care of the nursing home population should be considered a high priority, similar to wound care. Here we can see in the slide an overview of optimal practice and potential ways to improve nutritional care in nursing home residents. First of all, perform screening and periodic reassessment of dysphagia, malnutrition, and dehydration. Plan and conduct multimodal interventions and rehabilitation. Support the communication between the multidisciplinary team and dysphagia clinician regarding the recommendations and nutritional treatment plans. Involve a dietitian and food service manager to plan and provide a diet that meets nutritional needs. Assist residents with exercise to improve strength and decrease frailty. Provide specialized nutrition support as required. Perform a regular medication review with the aim of reducing medications that can negatively impact appetite or alertness. and ensure that there is at least one licensed supervisor present during mealtimes to oversee mealtime care quality, monitor symptoms of oropharyngeal dysphagia, and respond to acute needs. The goal for most residents should be to meet fluid, macronutrient, and micronutrient recommendations to maintain the best possible health status and contribute to the prevention of falls, fractures, functional decline, pressure ulcers, and infections. Evidence from previously published guidelines and expert-reviewed recommendations for the nutritional care of nursing home residents are summarized in this table. In a nutshell, we can say that energy requirements should be in the range of 27 to 30 kilocalories per kilogram per day, protein 1 to 1.5 grams per kilogram per day, fiber 25 to 30 grams per day, and fluids 2,000 to 2,500 milliliters. Micronutrients needs, especially those regarding calcium, vitamin D, and 12, should also be addressed. However, it should be acknowledged that quality of life must be the priority goal in residents with a short life expectancy. And for those who otherwise express a preference for quality of life rather than prolonged life, especially for these residents, management goals should optimize satisfaction from food and their mealtime experience. Consequently, the necessity of dietary restrictions, for example, salt, sugar, or reduced fat, should be carefully evaluated among these residents. As long-stay nursing home residents tend to suffer from various health conditions that can lead to or exacerbate oropharyngeal dysphagia, it is also important to consider the nutritional requirements specific to each condition, as you can see in the slide. For example, neurological problems, kidney diseases, pressure ulcers, or obesity should be taken into account. Some conditions are really prevalent in nursing home residents, so addressing specific recommendations for sarcopenia, frailty, fall and fracture risk, malnutrition, and dehydration is of paramount relevance. Recommended therapeutic approaches for the management of dysphagia include swallowing therapy and training, texture-modified diets, and technical methods, for example, a peripheral stimulation or transcranial direct current stimulation. But we also know that there are practice gaps between evidence-based management of oropharyngeal dysphagia and real-world patterns, which include, for example, insufficient nursing home staff and staff training, inadequate dietary provision, or some unmet needs, for example, regarding screening and management of both malnutrition and dysphagia, improvements to the quality of therapeutic diets, or minimal training requirements. Both oropharyngeal dysphagia and malnutrition are complex conditions that can result from factors presented here in the slide, regarding not only diet and care quality, but also staffing in the nursing home, for example, lack of nutrition and oropharyngeal dysphagia specialists. A lack of resources often translates into insufficient levels of staffing in the nursing home setting, and the inability to form a multidisciplinary team. The slide shows the potentially unmet needs identified by the committee that influence the diagnosis and management of dysphagia. For example, regarding perceptions and attitudes, we can say that cultural perception of dysphagia and older adult care may lead sometimes to inaction. Nursing home staff may feel pressured to ensure the achievement of nutrient dietary reference intake targets without acknowledging their residents' quality of life. Besides, sometimes dysphagia can be seen as an end-of-life symptom, but however, this does not negate the need for assessment and perhaps intervention if needed. In second place, we can speak about diagnosis. Inadequacy in the level and frequency of assessment impedes the prevention of dysphagia-associated complications. Due to the lack of consistent screening and the standards of care, it is unclear which professionals should be in charge and which tools should be used in the different stages of the screening and diagnosis process. And the lack of staffing and resources required for appropriate and timely diagnostic assessment of dysphagia is an ongoing problem in many settings. Regarding the management, a one-size-fits-all approach cannot meet the needs resulting from the complex and diverse manifestations of dysphagia. Lack of staffing resources and unavailability of an appropriate multidisciplinary team impede the assurance of proactive action to prevent malnutrition and adequate eating assistance. So we say that nursing home staff, professional caregivers, and home helpers should be provided with simple training in the management and detection of dysphagia, malnutrition, and dehydration. Although recommended to manage dysphagia, texture-modified diets provided for nursing home residents, when not well prepared, may be lower in key nutrients than regular diets. Adequate protein, fiber, liquid, and other key nutrients such as vitamin D, vitamin K and E, folate, magnesium, calcium, potassium, and zinc are the most difficult to achieve nutrients. A nutrient-poor diet poses a risk factor for infections, and insufficient liquid intake may lead to dehydration, which may in turn affect the degree of responsiveness and the functioning of the oropharyngeal tract. However, research has shown that these issues can be mitigated to some extent by good quality menus and recipes and hydration protocols. Yet high-quality intervention studies are lacking. Adherence to nutritionally enhanced texture-modified diets may have a direct effect on unintentional weight loss, dehydration, skin health, wound healing, and quality of life of nursing home residents, and may additionally exhibit a positive impact on nutritional outcomes such as improved mobility and independence when in combination with other interventions. Recommendations for the improvement and consistency of nutritional quality and improved adherence to texture-modified diets are listed here in the slide. Residents recommended by their dysphagia clinician to follow a texture-modified diet should be always referred to a nutritional professional. Texture-modified diets and thick with liquids, nutrient-dense or fortified foods are therapeutic diets and should be recommended for older adults with chronic dysphagia for improving nutritional status, promoting hydration, and minimizing the risk of aspiration. Concentrated, nutrient-dense commercial food products, especially made for dysphagia, may help to achieve the nutritional needs in residents and maximize food intake. Food should be enhanced with energy and protein-dense ingredients to prevent declines in nutritional and functional status. For those at risk of malnutrition, consider oral nutritional supplements to improve energy and protein intake, preferably offered as small volumes with medication rounds multiple times a day, between meals, and with the encouragement of carers. Adjust portion size as per the individual's needs and preferences. Offer a variety of options in flavors, optimal texture and thickness ranges based on the individual's abilities, to the greatest extent possible to decrease the rate of refusal, and to reduce mealtime fatigue and its associated risk of aspiration. Volume of sip or spoon size should be adjusted as per personal requirements. Aim to provide adequate food or fluid according to individual needs and preferences. Increase food attractiveness by presenting in a visually appealing and dignified way. Increase diversity and offer a range of alternative meal choices and protein and energy dense in between meal snacks. Personalize the ambience and delivery method to promote appetite and food intake, ensure that the use and intake of texture-modified diets and residents' nutritional status are closely monitored and evaluated, encourage eating but do not force food on residents. It is important to apply the International Dysphagia Diet Standardization Initiative framework to facilitate a consistent communication between nursing home staff, carers, and professionals, and reduce the variability in preparation, assessment, and prescription of texture-modified diets and thickened liquids. Rapidly and thoroughly evaluate the resident when they present with anorexia or refusal to eat while treated with a texture-modified diet. And important, the use of texture-modified diets should be reevaluated in the context of end-of-life and palliative care. We hope our approach may be of help for nursing home staff and especially for nursing home residents to decrease their risk associated to dysphagia and malnutrition. And we can conclude summarizing our facts that, for example, the population of long-stay nursing home residents is heterogeneous and complex, and is often characterized by the presence of one or more chronic conditions, with the addition of having a high risk of oropharyngeal dysphagia, malnutrition, and dehydration. Due to insufficient resources, inadequate staff training, and a lack of collective opinion on best practices, there is often a suboptimal approach to nutrition, hydration, and dysphagia care in nursing homes. And our paper presents, where available, evidence-based recommendations aimed to support nursing home staff and multidisciplinary teams in the preparation and execution of personalized nutritional care plans for long-staying nursing home residents who are prescribed texture-modified diets to manage their oropharyngeal dysphagia. Thank you for your attention.